So as Stephanie mentioned, I'd like to focus on some of the things that we've already been doing in the healthcare space prior to acquiring Cerner. Now, of course, we're very excited to stitch those things together with Cerner and create an even better system. But for nearly 15 years, Oracle has been a leading provider of clinical cloud solutions. Those clinical cloud solutions, primarily aimed at the pharmaceutical and biotech startup or biotechnology in general space, break down into two major categories. The first is clinical research, and that is everything from when a molecule is first discovered that could become a therapeutic or a vaccine or something in the future, collecting patient information during clinical trials, data collection, study startup, the overall portfolio planning, and everything that's required to take that molecule and eventually turn it into a therapeutic that is delivered or drug that's delivered to patients. The other piece of it that's very interesting is the pharmacovigilance business or drug safety business. So this is the process that goes on well beyond when a clinical trial ends. And when a drug comes to market, there needs to be ongoing safety monitoring for these type of situations for many, many years, 10 years minimum, some go on much longer. To give you an idea of some of the size and the scale of our pharmacovigilance database today, last year in the United States, in 2021, 91% of all vaccine adverse events were reported to the FDA from our Oracle pharmacovigilance database. So 91% of all safety signals were in the Oracle pharmacovigilance database. To put it in perspective, that's the largest single safety database in the world. Now, last year was quite busy with lots of new vaccines coming to market for COVID-19, but this has been something that we've been very proud to partner with our pharmaceutical customers and regulators throughout the world. 406 unique authorities were beneficiaries, including the United States FDA, across the world. Last year, we processed over 10 million adverse events. Again, it was an unusually busy year given the advent and scale up of COVID vaccines throughout the world. But that's what we do. We're here for scale. Our systems are built to scale for very large data sets, and the 10 million events were handled with relative ease. 3 million of those events came from one customer alone, a vaccine client. To date, we've managed over 250,000 studies and over 30,000 individual clinical trials. So chances are, if you're taking a medication today, somehow the Oracle technology has touched something along the process of getting that medication safely into you and providing you benefit. We're happy to count 28 of the world's top 30 pharmaceuticals as customers for our clinical systems. Now, what we're really excited about is the future. Clinical trials are changing. They have to change. They have to be more diversified. They have to be more inclusive. As Larry said, today, it's not uncommon for clinical trials to be heavily concentrated at very large university-led systems. That worked okay for many, many years. COVID completely flipped the script, if you will. In a pandemic where everybody was impacted, you have to be sure that as you think about bringing vaccines to market, in this example, that they're going to work for everybody. We want to be careful that we don't have a vaccine that's developed that doesn't work for a certain demographic, and that demographic was not represented in the trial. Even worse, we want to be careful that we don't bring something to market that causes harm to certain demographics or certain people that weren't represented in a trial. That has happened before. There are well-documented cases of certain therapeutics and certain pharmaceuticals in general that had underrepresentation in clinical trials, and not good things happen. That's why we're so excited about Clinical One. Clinical One, our brand new unified platform for clinical trials, is built to handle decentralized trials as well as traditional highly centralized trials as well. We can spin up new trials in days. It's simple to use. It's easy to do, and in fact, providers can do it themselves using metadata-driven configuration or composable application technology. This means that third parties, system integrators, Oracle developers don't have to get involved in all of the nuances that differentiate clinical trials. Customers can do that themselves. That, we think, is a huge new offering for clinical trials, and it's the only platform of its nature today that works in this way. It works in this manner. In fact, today, that Clinical One system, even though it's relatively new, is already in use at 33 countries throughout the world. Now, what's the next step for Clinical One? direct integration with Cerner EHR, Cerner Millennium, makes tremendous sense. We want to avoid duplication of entry. We want to make sure that providers only have to use one system when they're dispersing a medication and not have to double enter these things into two systems, as well as allow community hospitals and community points of care to participate in clinical trials at the same rate that large university-led systems are doing today. So during the process of the COVID Operation Warp Speed clinical trials, then called Operation Warp Speed, we developed a partnership with the NIH and the Fred Hutchinson Cancer Center in Seattle. This was an amazing outcome from what started as a very simple discussion. Dr. Jim Kublin, who was running many of the trials, in charge of the protocol for many of the clinical trials, called us, and I'll never forget this conversation. He said, we've got to get a lot of people into trials really quickly. We need to make sure that we have a very diverse population, and as much of the electronic pre-screening as we can do up front, we need to do, because we need to process people across 88 physical sites for these Operation Warp Speed clinical trials. And we need it to be really simple to use, because the general public has to be able to get into this and easily supply their information. We built a system very quickly that processed over 657,000 volunteers for clinical trials. In fact, that allowed the trials to not only meet, but to exceed their diversity and inclusion goals. In many cases, the diversity and inclusion goals for certain populations were actually exceeded. And that's really, if you know a bit about clinical trials, that's a very difficult thing to do, is to make sure that you have enough diversity in the trial. It's one of the single biggest things that slows trials down. We're able to meet and exceed that because we built a system that was so easy to use that the participation rates were so high. In fact, in under 10 minutes, patients were able to provide their full medical history, or at least enough of it, to know whether or not they would be qualified, or in some cases disqualified, for participating in this clinical trial. This is what we need more of. Healthcare systems that are simple to use, consumer friendly, yet very high value. I think there's this notion that because healthcare is very complex, that the systems have to be equally complex. I actually think the opposite is true. I think easier to use systems will increase participation rates and will have better outcomes as a result. Now, we've taken that same technology that we partnered with Dr. Kublin with at the Fred Hutchinson Cancer Center and now applied it for a brand new clinical trial spinning up for HIV vaccines. So there's a site launched in May of 2022 called helpendhiv.org in continued partnership, and it allows people, in the same way that they volunteered for clinical trials for COVID vaccines, to volunteer for a vaccine trial to help end HIV. There have been similar trials. There have been similar trials in the past for HIV vaccines. And in the first few weeks of running this, if you normalize the numbers, we will quadruple the amount of people that have ever volunteered for a clinical trial for an HIV vaccine just in the first few months. It's an amazing statistic. And when you put these consumer-friendly, patient-facing systems out there, people will actually use them, and that's a great thing. In addition to working with vaccines and clinical systems and pharmaceuticals, we've also done quite a bit of work with governments throughout the world. As you heard Sir Tony Blair refer to our partnerships in many parts of the world, we've created on-the-fly systems, composable application systems that were able to roll out vaccine management, appointment tracking, efficacy testing systems to governments where we simply replaced paper. In Ghana, for example, we rolled out this system, and since they didn't have COVID vaccine available at the time, they actually used it for yellow fever. We're able to track more vaccinations in the first 2 days electronically than had ever been tracked electronically in the history of the country prior to those 2 days. Replacing paper. Some of the stories that you hear are quite heartbreaking, in that there were vaccine records that are lost because of floods or fires because they're simply written down on pieces of paper. Obviously, there's still a lot of paper in many healthcare systems throughout the world. The fact that we can digitize these systems and we can roll them out throughout the world, and I'm happy to say they're alive in Senegal, Ghana, Rwanda, Tasmania, and others, not just for COVID-19, but for routine vaccinations and disease management as well. We partnered with the Oxford University to create the Global Pathogen Analysis System. You heard both Larry and Sir Tony refer to this. Let me add a couple new pieces of information here. The system created at Oxford was first was first scaled up to deal with tuberculosis and looking for variants of interest in tuberculosis. We were able to very quickly scale and migrate that to the Oracle Cloud and refactor it using a brand new UI with the Oracle Apex development environment. Within a matter of weeks, we had the system completely ported to the Oracle Cloud. The scalability went up by factors of numbers that are so big that you wouldn't even believe them if I told you. So let's say that we're in the orders of hundreds of thousands of records difference per day in order to being able to track. This system is now in use on almost every continent, 6 of the 7 continents in the world today. There are 40 governments throughout the world who are in line taking training to come in to start to use this system, not just for COVID tracking, but we will expand it to other pathogens of interest. Now, genomic sequencing, pathogen sequencing has been around for quite a bit, but what I'm most excited about is working with some of our partners. One of them is Oxford Nanopore, and they've done a tremendous job at taking the often difficult task of collecting a pathogen sample to the field. And they have devices that can fit in the palm of your hand that we can take out into the field. They're directly connected to the Oracle Cloud, and within minutes, we have the results of that pathogen sequence, and we can help public health officials determine whether or not a particular variant is what's called a variant of interest, meaning it would have some kind of a natural immunity because you were previously infected, or your vaccines would be ineffective against those vaccines. These are game-changing platforms that we think should be part of every government and every public policy, every public health administration's toolbox, if you will, for dealing not just with pandemics, but dealing with foodborne illnesses and anything that can affect and impact the general public. Larry also mentioned vSafe, which is the post-vaccination safety surveillance system, safety monitoring system to deal with folks who volunteer. Everybody here volunteered to supply their information after they received a COVID vaccine. This, for me, was the tipping point of convincing myself, and I think a lot of my colleagues would agree, that we could do something dramatic to change healthcare. I'll never forget, again, another phone call we had with the CDC. It was widely known that there would be lots of trepidation about COVID vaccines. There would be lots of angst and worry about, boy, these things came to market really quickly. Are they really safe? Are we going to have issues? And they said, can we develop a real-world tracking system so that we can get direct feedback from patients, direct feedback from citizens, not disintermediated by providers or having to go through older systems like the VAERS database. We need direct feedback. We're able to build that system in 68 days from kickoff to go live. It is now scaled to become the most comprehensive patient safety monitoring in the history of safety patient monitoring. Over 150 million patient reported outcomes are in this database today, and it continues to grow. On peak days, when there are major vaccination events, there are over 1 million concurrent users in the system at any given point. It's a staggering piece of technology, and what's great about it is it's staggeringly simple. So we can see here, these are sample screens, but on the left is, if you will, the public health official's view, so that they can see what's going on at any given time with real-time monitoring into all of those who volunteered. And on the right is a sample screen from the vSafe application. These are the types of intuitive applications and the types of intuitive decision-making tools that we need to put in the hands, and we will put in the hands, and we are putting in the hands of both providers and patients. Now, something very stunning happened today with vSafe. We put out a survey, a randomized survey to anyone who had used vSafe certainly a randomized population survey for all the population of people who had reported their symptoms using vSafe. Over 133,000 people replied to that survey. So I'm going to give you some statistics, and I want to be clear that I'm not talking about the law of small numbers here. 133,000 people replied. 96% of the people said the system was either highly intuitive or crazy highly intuitive to use. That crazy highly intuitive was at 90%. 90% of these people said this was the easiest system to use. I couldn't have imagined it would have been so easy. An additional 3%, so 99 total, said that they were completely satisfied with the usability of the system. When you round and you look at percentages, 0% of folks said it was either difficult to use or so difficult to use that they couldn't use it. In fact, 53 people out of 133,000 people said that the system was difficult. Less than 0.5% of the people said it was too difficult to use. Now, if you've ever done consumer application surveys before, and you've ever asked people for their feedback, you generally don't always get great feedback. Look at some of the survey sites and these things that are out there. When you ask 133,000 people for their feedback, you would think a lot more than 53 people would have a problem with it. Turns out they did. This is, I think, is a major confidence booster for all of us. We can create simple, highly to use, immersive systems, all built in a single database, giving providers all the tools they need, giving public health officials all the tools they need to create better outcomes and govern better public health. Okay, final section of things that we've been doing already at Oracle is on the payer side, on the healthcare payer side. So this is what I like to call a lot and a lot problem. There's a lot of money spent on healthcare, and there's a lot of money wasted on healthcare. $3.6 trillion, $265 billion. This is according to the Journal of the American Medical Association, is wasted due to administrative complexity. Yesterday, or 2 days ago rather, I got a check in the mail from my health insurance provider. It was for $12.50. It turns out that somewhere along the line, I still don't know where, when, or how, I overpaid a provider by $12.50. And I got a paper check in the mail. The immediate thought that I had was, well, that's pretty good. And the second thought I had was, how much did it cost them to figure out that I owed $12.50? Probably a heck of a lot more than $12.50. And so the insurance company then had to cut me a check for that. The provider then had to reconcile their books to reduce their revenue by $12.50. What a system that we're dealing with here. Something has to be done. Well, today, we're offering solutions for health insurance providers with over 100,000 administered members, 100 million administered members, 200 million global claims processed, generating $300 billion in annual premium revenue. So again, very large complex data sets, very large swag of the population here in the United States. We can do better. This industry is ripe for automation, and we need to figure out ways that at the time of care, patients can understand what their obligations are, what their financial obligations are, not 6 months after the fact. Now, usually you don't get a check, you get a bill. That was the first time I did get it. I did get a check. I usually do get bills, but I was happy that this time was a check. We need to make sure that all of that is transparent at the time the care is delivered, and we can do it with better automation. We also need to help patients understand whether or not they're going to qualify for a particular procedure or a certain pharmaceutical. It can take days, weeks, months to figure out whether or not you're going to get approved. That's true in single-payer systems as well. That's not just a phenomenon in multi-payer systems like we have in the United States. All of this is ripe for automation. We can do it. We can do it with an open ecosystem that we provide. We can also do it all the way at the same time that we're transitioning to value-based payments and helping providers understand the value of care given and how that turns into reimbursable revenue, not just in a fee-for-service model. Now, that may seem pretty bold. That may seem like a pretty bold endeavor, but we don't like to take on small things at Oracle. In fact, for 45 years, we've been at the forefront of managing the most complex databases in the world. Larry spoke about credit card databases and all of those things. I'm very positive and very confident that we can do the same thing here. We can create a system that's easier to use, and we can return all of that wasted money, or at least a very big percent of that wasted money, back into providing better care for patients. That would be a phenomenal thing. Some of our clients, as you see along the bottom, are some of the largest providers, some of the largest payers in the system today. We're thrilled. We're thrilled with the benefits that they've gotten today, even without the advanced automation that we'll build together with the Cerner applications. There's tremendous value, and we could look forward to continuing to partner with these clients and customers to further reduce the time it takes to process claims and further consolidate into single billing systems and have that available very timely and very accurately. So there you have an overview. Some of the areas that Oracle's been up to in the space, and you may not have been aware of any of these areas. Of course, we're incredibly excited to integrate all of this with the Cerner applications, and we think create an even more highly automated, highly efficient system that benefits both providers and patients. And we're going to do all of that at global scale. We're going to do all of that to scale to nations and to the globe. That's what we need. We need more. We need a lot more consolidation of data. We need a lot better information around it. We have the tools, the technologies to do it.